Yeah, I would echo Professor Nathan's comments, like, wow, great job, all the trainees, and the e-poster is also absolutely fantastic. So I think Professor Feldman's lecture, I think, kind of gave us the big picture kind of context, and we've been hearing a lot today about AI and machine learning, and this kind of reflects the theme of Gallie Day. And so we've put together a little symposium, and I want to thank Amin Madani in particular for kind of helping to coordinate this as well. And I don't know if those are my slides. There we are. Yeah, so, okay, our symposium, Artificial Intelligence in the Practice of Surgery. Where are we now and where are we going? And I think this really kind of reflects the whole theme of Gallie Day. And so I just kind of have a few slides. And so from the intention of creating a learning environment, I think, for all of us. And I think, we've been learning a lot. So, some definitions, AI. So, it's clearly a field focused on automating intellectual tasks that are normally performed by humans. And we've been seeing, some of the advantages, but I think also some of the limitations. But it's clearly it's an evolving a field. And often AI, at least the current algorithms, don't always work so well in situations that require higher level pattern recognition. This is still something, I think, where the human brain and the human eye still are not entirely matched by machines. But of course, this may change, obviously. Then there's machine learning. This is really kind of, if you will, in a sense, a form of AI, but kind of a very specialized form of AI. And this is really can be thought of more as an advanced statistical algorithm. And this is where one uses subsets of data to generate an algorithm that might use novel or different combinations of features that can be derived from first principles. And then these can be either supervised, so where the human being, the statistician, if you will, is supervising the model, entirely unsupervised, and then combinations of these. And you'll have seen that several of the talks today that were using machine learning use several different algorithms because one needs to actually kind of have internal controls for the validity of this. And then there's a whole concept then of artificial neural networks. And this is really kind of inspired by the concept of biological neural networks. And we saw a beautiful a talk from George Ibrahim's lab, kind of looking at some of the neural circuits related to human behaviors. And so this is evolving, and the reality is, I think we can kind of see through this a complexity that there's different ways to interpret this. And then there's this concept of deep learning, and this is really where the application of artificial neural networks occurs with multiple layers of data processing to produce higher levels of features. So our professor is from McGill, so I thought I would actually kind of bring this down to kind of my level, and this is, I think, really a very nice article from our Canadian journal, and I think Professor Harvey is at McGill, and I think Professor Ball is in Calgary. And I would commend this to you. It's a very nice, very easy read. It's open access. And it kind of talks about, the yin and the yang, if you will, of the application of AI to surgical practice. And it's quite, it's evolving. And we've heard a number of elegant presentations on large language models. And these are constantly evolving. And it's actually quite remarkable how these can augment human decision-making. And I think the application that we just saw, with the trauma decision-making, I found that really fascinating. And that actually made a kind of a lot of sense to me. So this is clearly an evolving field. I thought this was actually a very nice editorial that just came out like about a month ago. And this is interesting. This just came out in the Open Access JAMA journal. This is actually a randomized trial. And we saw some other articles that were kind of making reference, to this, and we heard this before, where it's not entirely, clear cut that these models may augment human decision making, and this might be because there might actually be human training that's involved in the use of this. And to me, that kind of makes sense, right? It's like any kind of a technology. You probably need to be trained in terms of how best to apply this. So I thought this was kind of interesting. Okay, so that's just kind of a refresher to set the stage, and I just would like to just briefly introduce each of the speakers, and then we'll have each of the speakers give a 10 to 12 minute talk, a little bit of discussion for each speaker, and then we'll have a panel discussion, and I will invite our Gordon Murray professor, Dr. Feldman, up for that. So Amin Madani, I think, is known to all of us, but he's an endocrine acute care surgeon at UHN. His research focus kind of relates to the use of technologies to enhance and optimize performance in the operating room, and he's certainly been very, very innovative in this field. Whoops, I think I need a large language model here to help me with my clicker. Oh, there we go. Okay, whoops. Oh, very good. Okay, so Dr. Mamatha Abbat is a hepatologist and clinician scientist at UHN's Ajmera Transplant Center. She's associate professor, and she's from the Department of Medicine, and I think it's really quite appropriate that we have a physician here as well, because as we know, surgical care is a multidisciplinary team sport. And Dr. Bott's research program is focused on long-term outcomes of liver transplantation, and really interesting using tools of AI to enhance this. So I'm really kind of excited to hear this talk. Dr. Mamdani, and we've seen his influence in a number of the presentations today, and he's multi-talented. He's had multiple hats, and I won't read all of the words here, but he's a professor in the Department of Medicine, holds several important leadership roles at Unity Health Center, very involved in the AI field, and is also a great teacher and mentor, as we've seen. And I have a personal association with the next speaker by way of disclosure, and Lorene just recently completed her PhD, co-supervised by Charles Tatter and myself, and I thought it might be appropriate to show the use of AI types of techniques to look at really big data that arise from genetic data sets. And so we've heard a lot about the use of clinical data, but I think the future will also entail, in all medical practice, but certainly in our surgical practices, trying to get a handle on the influence of genetics in terms of influencing phenotypes and so on. And I think Lorene's work may give us some insights into that. So with that, last but not least, Dr. Chahal will give us a brief update on kind of innovation entrepreneurship, and certainly there's a number of emerging AI platforms in this space, and Dr. Chahal is a very talented orthopedics sports surgeon. He's involved with a lot of the teams, and he's also multi-talented with degrees in ClinEpi and also an MBA from Rotman. So we've got an esteemed panel here, and to lead things off, Amin, please take it over.
Thank you, Dr. Fehlings. Good afternoon, everyone. It's really been a pleasure. Thanks for asking me to participate in today's events and to plan everything. And thank you to our visiting professor, Dr. Feldman, for coming today. So we're going to talk about surgical AI. These are my disclosures. I'm not going to talk about anything related. So I'm kind of the first speaker, so I thought I'd give like a little bit of an overview of AI, machine learning, some of those definitions, and I'm going to try to give an overview of some of the potential applications of AI as surgeons, and just to kind of show you the world of possibilities. But I do also want to touch on some of the challenges as well in terms of bringing this in the operating room or in our practice. So what is AI? I mean, we've already talked about it today, so I'll be very brief, but AI, as you heard, is a study of computer science that gives machines the ability to do things that we humans were traditionally thought to only be able to do, like decisions and judgment and perceptual functions and things like that. And generative AI has really taken over in the last several years. Generative AI, basically AI algorithms that can produce new content like text, images, videos, computer code. AI algorithms can write manuscripts, essays. We've all heard about ChatGPTs, and there's a lot of large language models out there. It can write a manuscript for you. It can write a poem or a song about surgical AI. It can do all sorts of things for you. And this is kind of the old versions. The newer versions can do more complex things like a thematic analysis of text information. So this technology has become really advanced, and you can do anything. You can create videos, deep fakes. You can take a snippet of someone's audio and then make it seem like they're talking. The technology has become very scary. You can put in prompts and it'll create random things for you, like a painting of a hernia repair in the style of Picasso, like random stuff like that. And so, there's a lot of hype around this. Even our computer scientists in our lab, they actually use large language models to create computer code, so they don't have to type out all the code anymore. So this has really helped their workflow. So anyways, this has really permeated society and on so many levels, and this has also spilled into healthcare. There's not one specialty out there that's not been affected in some way by AI, and we surgeons as well, we're starting to feel it as well. Developed here, at our own by Bo Wang, at UHN, Clinical Camel. It's like a large language model for medicine, which can summarize your clinical interactions. And there's actually a ton of these commercially available softwares that are available that can basically listen in, on your conversations with the patients and summarize an entire clinical interaction for you. So this is going to really start to impact us soon. And we have teams of AI deployment at our hospitals now responsible for bringing this in. So we're going to see a lot more of this. So we talked about some of these definitions. Just to kind of summarize, machine learning is a type of AI. It's basically what's made AI very popular. Basically programs that can look at patterns of data, make sense of it, and then be presented with new data it has never seen before, and then make predictions that are accurate. And there's different types of these. Deep learning is a subset of that. It's just a class of algorithms that are very, very powerful. Different ways you can train an algorithm to make predictions. Supervised learning is the most common one in some of the early prototypes. Basically, it's saying, okay, AI, I'm going to train you to do something. Here's hundreds of thousands of examples until you become really good at picking that up. So you take your data, you annotate it, so you label it. You say this example is this example is that, and then you train your model. And eventually you have a model that can take new data it has never seen before and predict. There's also unsupervised learning, which is, it doesn't require labeling. Basically, it's saying, okay, AI, here's a bunch of data, make sense of it. Find me like patterns in that data. And so that's how it is. So whenever you have recommendations for, Netflix or, Amazon recommends to buy this, you're in a cluster and it has determined what you're prone at buying. So that's actually quite implemented these days. And in reinforcement learning, Lawrence gave a really good talk on mass casualty incidents. It's saying, okay, AI, I'm going to train you to do something. Let me put you in a simulated environment, and you can practice through trial and error until you become really good at that. AI can do computer vision, track objects, detect objects, tell you what's happening in the surgical field, and so on. So let's talk a little bit about some of the applications of surgical data science. There's a lot of different things, and I'm not going to give you a comprehensive overview, but just to kind of give you some examples. My area is in computer vision, AI algorithms in the operating room to provide you with decision support, augment your performance. Sort of think about it like a co-pilot during surgery. This was our first sort of prototype, gallbladder surgeries. AI algorithms that can tell you where it's safe to dissect, this go zone, and then where not to dissect, the no-go zones, and this idea of projecting your mental model on the surgical field. So this is kind of like one of our first works that we did. We've applied these algorithms on videos of bile duct injuries like this video, where that there's unfortunately a bile duct injury happen here. You can see the AI algorithm is saying keep the dissection up there. That's a heat map in red. Unfortunately, just a little bit lower is the common bile duct. And the idea is that having an algorithm like that that can give you an early warning signal to keep your dissection higher, something like that. And we've expanded this to other subspecialties, whether it's breast cancer, colorectal. We're working with Dr. Yasufuku on doing this for lobectomies, Dr. Zadeh, who's left us, but for endoscopic pituitary surgery, colorectal surgery, finding the oncologic plane. We've done it for AAA repair, endovascular surgeries, and also critical view of safety for gastrointestinal surgeries. So there's a lot of different use cases now. What about education? We've heard a great talk, so I'm not going to go into a lot of detail about that, but there's a lot of ways we can use AI to assess our performance, evaluate, based on our performance in a video, how good we are, whether or not we pass a certain benchmark. We've heard a lot of using it for certification, and there's a lot of examples of that in the literature. AI algorithms can track all your hand movements, and you don't need fancy cameras for this. You can take a webcam, move your hands around, and it'll track every joint in your hand spatially for you. And people have used this to be able to predict whether or not your hand movements are very characteristic of experts versus non-experts. And it can do this for your instruments, your tools, and so on. What's really consistent in the literature is that AI is really good at replicating what expert raters would predict, but what's really impressive is that it's not only good at predicting, but it does it with very good low variability, so it's a lot more consistent than human raters. A particular area for me that's interesting is using assessment for coaching, using it to give feedback for people. So this is an algorithm we developed in our lab on an AI algorithm to tell you how good your retraction is. So this AI model is able to tell you, like for instance, this is inadequate retraction here, so use your left hand more or something like that. There's other algorithms. This is a really interesting one where they actually look at how red the surgical field is, how bloody it is, and it correlates well with your tissue handling scores, for instance. So there's a lot of different opportunities there. One thing that for me was really exciting when we were doing these go zones and no-go zones was really nice because it outlines the anatomy, but it doesn't tell you what you're doing with respect to that anatomy. So one of the projects of one of my master students, Ziad, is basically developing an algorithm that tells you when you made contact with the tissues, what instrument you used, what kind of dissection you did, and where you did it. And so you can correlate that with that anatomy to give very tailored feedback, and that's going to be the next step. We've gamified these as well. We've developed these apps that you can download as trainees, and it says, okay, where do you want to dissect? And you say, okay, I want to cut here. And then the AI algorithm will give you accuracy scores based on that. It'll give you feedback based on what you did, and there's also a leaderboard to make it fun. Another area that's, I think, really cool in education is using this generative AI stuff. We talked about, there's a lot of algorithms that can do 3D reconstructions, but then taking this to the next level and actually creating deepfakes of surgical videos. So that video on the bottom is a deepfake. It's not a real laparoscopic video, but it's based on the top video. And you can kind of apply these models to make it simulated and use it for preoperative planning. That's very new, and I think in the next 5-10 years, we're going to see a lot more of that. I skipped over perioperative care because some of my other panelists are going to talk a lot more about that, but basically AI is, there's a lot of examples you've heard today about algorithms that can predict postoperative outcomes, who's going to deteriorate in an ICU in the next 12 hours, and things like that. There's also really cool models that'll look at the vital signs in the OR and tell you which patient is going to become hypotensive, for instance. So there's a lot of cool applications there. Another area that I think is very exciting is healthcare processes. Not the area that I traditionally went to, but I think there's a lot of potential there, and AI is actually very good at this. AI algorithms that can map out exactly what's happening in the operating room, whether you're in the middle of turnover, at the beginning, prepping, draping, closing, and so on, and it can tell you what's happening in the surgical field, what tissue's being dissected, and with what. So you can imagine an operating room trying to optimize its efficiency could really find algorithms like this useful, so they know when a room is ready for turnover, so they can start the process and plan accordingly. Not just within a hospital, but also outside of the hospital. We talked about mass casualty incidents, algorithms that can help triage patients on a city level as well. And I'll skip over that since you already heard the talk from Lawrence, but an algorithm that can make suggestions on where to triage patients during a mass casualty. And you can use this in education or in a real life Code Orange. And then finally, I'll just mention one slide on automation, because this has become really a big topic. There's a lot of discussion about, is AI going to be used to replace surgeons and things like that. And I don't think, that's, if you think about robots right now, it's sort of like this master slave where surgeon still controls everything. So the idea is giving AI the ability for, the robot to do things. And I don't think we're going to see Terminators walking around in our hospitals or anything like that, but it could be something as simple as, the laparoscope is going to move around with your instruments autonomously, or something that's going to suction for you while you're doing surgery. Johns Hopkins just put out a really cool algorithm that is able to do suturing, a robot doing suturing on its own. So there's a lot of cool stuff coming our way. I do want to touch on some of the challenges as well. I'm not a skeptic. I'm an AI enthusiast, as you mentioned earlier, Dr. Feldman. But we do have to be honest with what we can and can't do. And bringing AI to the operating room is a very, very challenging thing. Just because you have a model, bringing that in the OR or operationalizing is a major problem, and there's a lot of steps there. Not to mention the legal, the privacy, the ethics, and all that goes behind it. Everything from infrastructure, understanding how to deploy it in a real life setting, scaling it to low resource settings. If you have no network connectivity, how do you bring the AI? AI is also very good when you train it on your own data set, that's great, but it's also notorious as being bad the moment you go to another place across the street and you haven't trained it on that data set. So generalizability is a problem too. There's different ways to train models, and you want to optimize your algorithm for that specific setting. And there's also a lot of design considerations. Infrastructure is a big problem I mentioned. You can bring the AI from the cloud, or you can bring it in the operating room, and there's different advantages for one versus another. If you're going to have it in the cloud, well, there's security problems, like how are you going to send that data to the cloud and back, and moving videos through the cloud and through the network is very hard. It's like very big data. But if you're going to have a hardware in the operating room to do that, then you're going to consider like integration with your IT, and there's other problems like that. A lot of our work in the lab has been on creating that kind of infrastructure, and the world that I envision is, you're going to be in your OR, and it's kind of going to be like your app store, where you go, okay, this is the AI model that I want to use in this surgery, and you kind of select it and you deploy it. And this is not something, science fiction. We've actually done this. This is a 4th floor OR in Toronto Western Hospital. It's not an integrated fancy OR. It's, you can see, but you can still bring the AI model there. It's totally feasible. And there's different ways to skin the cat. Like you can train AI models to do there's different ways to, different AI models you can do to do the same thing. Some AI models are very efficient, more accurate than others. Some are, worse for the environment. Some are, computationally more heavy than others. Some are better for real time. Some are better for not real time. So there's different ways in which you can do that. And all of that is part of the decisions you need to make for operationalizing. And finally, design is a problem. So you're a surgeon and you want to bring AI in your OR. That's great. How do you want your AI? Do you want it on demand? Do you want it always there? Do you want it as a fly in the wall that just interrupts you when needed? Do you want a heat map? Do you want only when it's very confident? All of these are issues that come up. And ultimately, you have to evaluate its performance. And for all the hype about AI, there's very little data that actually supports improvement in clinical outcomes. So it's important to be data-driven about this. So in summary, AI is a very powerful tool for improving surgical care. There's a lot of use cases in data science. I kind of give you like a big lay of the land of all the different things that I think AI can do for us. Computer vision, which is my area, is for real-time guidance, is really early infancy, and there's a lot of obstacles for operationalize this thing. But ultimately, you can use this kind of technology for improving quality, safety, democratizing surgical care, and improving things like resource utilization. Just want to acknowledge everybody in our lab and the honor of the podium. Thanks.
Amazing. I think just kind of looking at the flow, what I think on reflection is we'll maybe hold off questions until the panel discussion. So next up is Dr. Mamatha Bhatt, who will talk to us about the development of multimodal AI models to personalize the care of transplant recipients.
Okay, great. Well, good afternoon, everyone. I'd like to thank the organizers for the kind invitation to present to all of you today. As Dr. Fehlings mentioned, I'm a hepatologist and clinician scientist, and I co-lead our Transplant AI initiative, which is dedicated to both developing as well as deploying AI tools across our transplant program. In terms of my own research program, I have a computer science heavy team, so mainly graduate students and postdocs in computer science comprise over half of my team, and the other half is bioinformatics and clinical fellows. So we have a very nice exchange and very nice learning opportunity from people who have different skill sets and different languages. So these are my disclosures, including industry and peer-reviewed grants. So I'll start off with why machine learning in transplantation and get into some key projects that my group has been working on. So for the sake of time, given the constraints of time, I'll really focus on some of the key projects that we've been working on along the transplant patient journey. So these include optimizing equity and candidacy and waitlist prioritization, optimizing patient survival as well as graft survival in liver transplant recipients. So we'll start off with why machine learning in transplantation. So I was particularly inspired in using AI tools because of the diversity of data and the patterns in data that I was recognizing in the patients I was taking care of. So as a transplant hepatologist, I look at a lot of blood test results, and I take into consideration the individual patient characteristics in order to make a determination as to what is the correct diagnosis or what is the right path forward for this specific patient. And so what I liked about AI tools was the opportunity to distill all of the complexity, diversity in the data, hidden patterns, and interrelationships among several variables, and then fine-tune that model in my own institutional data to then generate individualized predictions for the given patient in front of me. Because I realized I was trying to do that in my day-to-day practice. Now, the reality is that the human brain can only deal with 7 variables at a time, notwithstanding longitudinal changes, because we also consider the history of the patient, the history of the blood tests, when we want to generate predictions for that individual patient. Now, there's so many different variables that we consider, different types of data. We've summarized this in various reviews in the last years. The additional inspiration for using AI tools, I think, is bringing objectivity to decision making. So you've heard this, I think, during the day. But as a transplant physician, I feel that there are many decisions that we make in day-to-day practice that are slightly tainted by subjectivity. So there is some subjectivity in terms of decisions around candidacy for transplant, in terms of identifying suitable donor organs, waitlist prioritization, donor-recipient matching, and prediction of outcomes. And I really felt that we could do much better. So I think there is this opportunity to bring objectivity, and I'll discuss this in subsequent slides. This is taken from a review we published in Journal of Hepatology 2 years ago, and it summarizes the AI and liver transplant literature. So I'll start off with optimizing equity in candidacy and waitlist prioritization. And so first of all, you heard a lot about large language models in the recent talks. One important project that we've worked on in the last year is the use of AI agents to obtain, the most objective decision possible. So we considered AI agents to represent the different sets of expertise on the liver transplant selection committee. So an AI agent is a large language model that can have a domain of expertise that then can be used to obtain a decision or provide a decision around a certain problem. So this was actually inspired by a discussion with Mohammed, and he's a co-author on this. But basically, I felt that we should try to replicate the liver transplant selection committee with AI agents. So what we did was we trained we fed over 8,000 cases, 7,000 of whom had been listed for transplant and had received a transplant, and we took 1 year survival as a surrogate as to whether that patient was a suitable candidate or not for transplant. And then we took over 1,000 cases that were representing absolute contraindications to transplant. Then we asked each AI agent, so the AI hepatologist, the AI surgeon, the AI anesthesiologist, and the AI social worker, to review each of those over 8,000 cases and then come up with a decision as to whether that patient was or was not suitable and what their rationale was for accepting or declining. And then we asked them to come to a decision altogether around, whether this patient was or was not suitable and what was their rationale as a committee. So the idea here was to really replicate that selection committee and provide as objective decision as possible. So this AI selection committee actually was able to accurately identify those patients who would benefit from transplant with a 92% accuracy. So very interesting proof of principle that, of course, we need to validate prospectively, but it provides you some, opportunity or understanding as to what the future of such, tumor boards or selection committees could represent with an AI agent as an additional committee member. Okay, so next I'll move on to another project that is funded by the CIHR, and this is inspired by inequities in liver transplant allocations. So certainly over time we had noticed that there were disparities in terms of female patients being able to attract organ offers, PBC patients because of the underweighting of the bilirubin in the MELD scoring system, as well as shifts in the underlying patient cohort over time. Additionally, the reality is that there are dynamic trajectories on the waiting list, and so patients with acute on chronic liver failure, for example, have very rapid changes in their blood tests and their clinical status within a very short time frame. And the reality is that the MELD score does not represent the reality, the real severity of their disease at a given point in time. So their instantaneous MELD does not really reflect. So we felt it was very important to try to change this system. And so this is work led by a PhD in computer science student, co-supervised by myself and Rahul Krishnan. So Michael Cooper is the PhD student, and so he developed a deep serve algorithm, which is a deep learning version of the Cox-PH model, but modified for rates of change. So he trained this model on over 53,000 patients listed for transplant with decompensated cirrhosis, 13 static and time-varying covariates per patient, considering the velocity and acceleration in all the blood tests over time. So at every given time point, velocity and acceleration were also considered. And by doing this, in fact, we determined that the concordance index, 90-day concordance index, was significantly higher with our score, which we called DynaMELD, as compared to the MELD 3.0. We then looked at its performance in terms of fairness. So there is a certain measure called the PGCI, or Pooled Group Concordance Index. And we looked at how fair this model would be for those groups that have traditionally been disadvantaged, including women, PBC, small-statured patients. We also looked at ACE CLF performance. So certainly it was significantly able to advantage those patient subgroups who have been relatively disadvantaged. Then we moved on to interpretability, so Shapley analysis. So Shapley analysis is a way to identify what are those features that are most predictive of a certain outcome. So this is the Shapley analysis for this algorithm for the overall patient population. Reassuringly, the first 6 parameters are the parameters that are currently in the MEL 3.0, which is reassuring. However, the reality is that many patients, as represented by dots, have their top feature as the first order change, so the velocity in those blood tests. And so you can see that in the bottom over there, you can see that, say, the fact that someone has PBC, the fact that they've had changes in their velocity over time in the blood tests clearly was very important for a certain subgroup of patients. And so by using the MEL 3.0, in fact, we are disadvantaging certain subgroups of patients. So then you can look at individualized interpretations of dynamic trajectories and look at the weights of those features in that independent individual patient's risk of mortality or dropout. So for example, for this 50-year-old woman with PBC, the fact that she had PBC was the most important factor. You can see it's the top factor. However, by 132 days after listing, the fact that she had been started on dialysis within the last week was the top predictor. And intuitively, we know this as clinicians, but the nice thing is that having Shapley analysis as the interpretation is really helpful to engendering trust among clinicians, because it's what your clinical intuition would tell you. Okay, so now I'll show you quickly what we've now done. So we've run now a silent trial of this tool via Epic. So our data engineering expert, Peter Maksimowski and Mike Broodmo, have been integral to doing this, but we've managed to integrate this into Epic with automated flow of all those variables, as well as those velocity, acceleration, et cetera, to generate individualized predictions for a given patient, and then look at the dynamics of the Dynameld over time, as well as the Shapley analysis you can see in the upper left-hand corner, as well as the relative risk of that patient in comparison to other patients on the waiting list. And by doing that, in fact, we determined that many of those disadvantaged patients would be appropriately upranked, whereas those who could actually wait were downranked. So, really showing to us that our scoring system would have great opportunity to kind of restore or, provide equity to those patient subgroups that have been disadvantaged thus far. Okay, so now I'll try to finish up quickly with post-transplant patient survival. So this was a paper we published a few years ago with Bo Wang and driven by Oswald Nitsky and Amir Ajay as a computer science undergrad and a clinical research fellow. We were interested in developing a personalized risk calculator for managing long-term transplant care. This was a transformer model. Now we tried to deploy this model, but unfortunately it was computationally too heavy for Epic to manage, and so now we have, kind of pared it down to just a CV risk prediction model, just to tell you that it's not easy to actually deploy some of these very heavy tools. But so that was a publication in Lancet Digital Health because I think it was an interesting application of a deep learning tool to liver transplant care. And now a second tool that we developed, actually driven by Divya Sharma, who's a postdoc I co-supervised on this project, but she developed a novel method in order to address certain issues with the data set to predict dynamically the risk of graft fibrosis. So she considered longitudinal changes in several clinical and laboratory variables, and she applied a certain weight loss function to a deep machine learning method and created a new method called the weighted long short-term memory network, which achieved an AUC of 0.798 for the detection, diagnosis of significant graft fibrosis dynamically over time. And you can see the top-ranked features are also intuitive: recipient age, donor age, transplant primary indication. So now I'll conclude quickly with a project that now is accepted in Nature Communications. This is a multi-class artificial neural network, and this is, a tool that can classify, liver transplant pathology into 6 categories. So it's not a binary outcome; it's a multi-class outcome, which is the reality in liver transplant recipients. When they have elevated liver enzymes, you consider these 6 major categories. So rejection, MASH, and other issues. So the average AUC overall, the classes for this ANN was 0.866. And we evaluated how this model performed versus hepatologists. In fact, the ML model was better performing overall compared to hepatologists. However, it did not identify certain key features that the clinicians identified. So then we thought, okay, well, why don't we teach this model to better learn what the clinicians intuitively know? So we brought the human into the loop to teach the model further, applying Bayesian inference principles. And in fact, by doing that, we improved the performance of this model overall. And then we externally validated this algorithm across 3 continents. So we externally validated this at Mayo Clinic, NUHS in Singapore, and Hanover in Germany. We sent them the code rather than doing any data transfer. And actually, this algorithm validated quite well at those 3 other institutions. So demonstrating generalizability for this particular problem, although the performance was slightly less actually than at UHN. So I think overall, in summary, in this particular patient population, I think the exciting thing is that AI tools offer the opportunity to, bring together that complexity in the data and consider the dynamics over time to ultimately generate personalized predictions. Additionally, bringing objectivity to the decision-making we have in transplant. There are various next steps, I think, that are very exciting in the future of AI that I'll be happy to discuss in the panel. I'd like to acknowledge our Transplant AI Initiative members and members of my very enthusiastic research team, as well as collaborators, and also our funding sources. Thank you so much for your attention.
Fantastic. Really, really interesting seeing the application of AI in the management of these complex transplant recipients. So the next speaker is Dr. Madani, who will talk to us on the art and science of applying artificial intelligence to clinical practice.
Great, thank you. As I was kind of walking down the hall, I thought, Gallie Day surgeons, I didn't wear a jacket. But I see a half a dozen men here who didn't wear jackets, so we're not alone. All right, terrific. So with that said, we'll get started on the talk. If we go to the next slide, there's a video to play.
Robot is currently making its way down.
The future of surgery will look like this.
We are developing surgical robots to make the surgery safer, faster, less prone to errors, and less costly.
At the Montreal General Hospital, they're unveiling a new surgical robotics center, developing the next generation of robot surgeons powered by AI.
The artificial intelligence basically learns the techniques and nuances. Then we use that to our robots.
Amir Hushiar says AI uses data to make surgeons better at their job. The center is the first of its kind in Canada.
Because it's located directly next to the hospital, which gives various doctors from all different types of disciplines, orthopedic, trauma, surgery, many different types of surgery, the opportunity to come here and develop new techniques.
Robots helping us surgeons do the impossible.
Dr. Ahmed Awood says robots help reduce surgery time.
The shorter the surgery, the better your outcome is. You have less pain, you have less problems.
These tools are becoming more common. The Health Sciences Center in Winnipeg recently got its first ever surgical robot, which has helped reduce wait times for surgeries and make procedures less invasive. That said, robots are not taking over.
Doctors, surgeons must always be in the loop of surgical robots taking over some parts of the surgery, not the whole surgery.
And so while your doctor may never be replaced by a robot, the extra help is welcomed. Sweet Arasi, CTV News.
I had to show the video. This was actually just a couple of days ago. I was thinking, what am I going to present? And I saw this, and it was like a gift, right, from up there. And of course, I see the video, and I see the one comment that was posted, and it said, "Remind me to not fet surgery in Canada." There's a lot of hype. There's a lot of interest in this space, and I think we're seeing a lot of action that's starting to take place. I got to say, centers like that, I was in Shenzhen a couple of months ago in China, and they launched theirs, which was really exciting. There's just some really cool, innovative things. Not sure if it's quite ready for prime time, but you can see where people are starting to put in resources and effort because they see this as a very good area to invest in. I'm going to actually make sure that I actually stay on time and not go over by too much. There's lots of applications of AI in surgery, and we see a lot of research in these spaces, whether it be surgical robots, preoperative planning, intraoperative assistance, post-op care, training simulation, and so forth. But of course, we want to know about what can be used, and are there any use cases or outcomes-based studies where we can actually say, or just something that seems to work in practice, where we can say, aha, that seems really good. We've seen touches of that here, which is really super exciting. So I can tell you, I'm going to go through some examples at different places. At Unity Health Toronto at St. Mike's, Dr. Chris Witch, who's a neurosurgeon, led this with our AI team. His whole passion was, all right, traumatic brain injury. How can we actually identify patients who need immediate operations versus those who can wait a little bit versus those who probably don't need surgical interventions? For a level 1 trauma center, with neurosurgeons and 24/7 neuroradiological services, probably not as big of an issue. But you can imagine all the consulting hospitals or the hospitals outside coming in with consults. It takes a lot of time for neurosurgeons to review. So at St. Mike's, if you go into the clinician area and in the emergency department, I think we're going to be putting it back up soon. We just transitioned to Epic, and that threw us off quite a bit, but this will be up and running soon. We have this monitor that is running. Basically, it screens all of our patients where they're located. The emergency medicine physician is looking after them, the radiologist who's looking after the test they ordered. And under status, every now and then you're going to see this thing that says ICH for intracerebral hemorrhage. That's our AI. So in real time, it's actually screening. Every single head CT that's done at St. Mike's goes through our AI system. And in just over a minute, it will detect an intracerebral hemorrhage. Why is this important? Because studies have shown that 10 to 20% of bleeds are missed in most hospitals. 10 to 20%, right? So it belongs to a parent algorithm called traumatic brain injury, again, developed by Chris Witchu and our folks. We compared it to 5 board-certified neurosurgeons and over about 3,000, almost 3,000 cases worth of data. And we showed that it performs just as well as neurosurgeons. In fact, it misses slightly fewer cases. So this should probably be in most community hospitals. We get a little bit of benefit out of it, but you can imagine hospitals that don't have the neurosurgical services or supports would gain a lot more, I think. I promised Amin I would just say, look at this, that guy. He's already went through this, about this real proof of concept that could actually be used during a procedure. I think it has tons of potential. Again, at St. Mike's, we have something called ChartWatch that's up and running. We actually developed an early warning system. Why? There are other early warning systems out there. Epic has one. There's News 2. They don't work well. Too many false alarms. They alert everybody. Nobody listens to them. Just to give you a sense in terms of alarming frequencies, News 2 would have alarmed our team 15 to 20 times a day. Epic's solution would alarm 12 to 15 times a day. This alarms 1 to 2 times a day. And it's actually much more accurate. So the way this thing runs, it monitors all of our internal medicine patients. We've actually deployed a version of this on our general surgery unit. It tracks all of our patients every hour on the hour. So every hour it's monitoring our patients and typically considers between 150 to 170 different parameters, from demographics to labs to vitals and so forth. As soon as it reaches a high-risk threshold, it's automated to page a medical team. Our protocol is the medical team has to come and see the patient within 1 hour being paged. It's been running for over 4 years now. We published a paper in the CMAJ last September showing a 26% reduction in unexpected mortality. So these are not hypotheticals. These are actually things that are being used. If we take a look at Women's College, there's a really neat tool there around an orthopedic surgeon who said, you know, if my problem is I don't have much time and patients have a lot of questions. And sometimes I don't have patience for patients. So can I have a chat bot kind of connect with them and kind of go through some basic issues and problems with them? after they go through knee arthroscopy. So I believe they call it Fehlings. And at any rate, so they deploy this, and a bunch of patients start using it, and it actually starts answering mundane questions that oftentimes you don't have time for. And it gives them all the time in the world because, well, it's a chatbot. It has nothing better to do. They found that 80% of patients rated the helpfulness as good or excellent. So you can imagine pre-op, can you prep a patient? Can you have an LLM with RAGs and just basically get it to answer some basic questions, prep the patient a lot better than we could because you don't have the time? And even post-discharge, can it actually handle patient queries? It probably could. And according to this study, it may actually work quite well. There's a lot of things that can go wrong with these algorithms. And so organizations like ours actually have responsible AI implementation of AI frameworks. And the way our framework works is we focus on clinical validation first and foremost. What we mean by that is that when we actually develop these algorithms, let's say it's a prognostication algorithm. I loved Mamata's study around, she actually asked doctors, medics, and compared them to the tool. People don't do that enough. We need more of that. Because I'll tell you, when we're developing ChartWatch, the thing that predicts if somebody's going to die or go to the ICU, we had a room of 17 internists, I remember the day, and we asked, well, why should we create this early warning system? Because aren't you good at it? That's your job. And we had a bunch of internists say, I'm terrible at it. I'm not good at prognosis. And we had 3 or 4 say, I'm amazing. I'm so good. I'm phenomenal at this. We said, well, what's the truth? We looked at the literature. There was not a single study studying how good physicians are at prognosis in this situation. So we went to the floors. And we asked our doctors, nurses, and our residents, in real time, this is not a case vignette, it's not a hypothetical case, you just finished rounding on this patient. So you know them. Tell me if they're going to die or go to the ICU during this hospital stay. Predict, because that's what you're asking the AI to do. If we don't know how good you are, how can we develop an algorithm that has good enough performance? Because we need to know that it beats you. So we collected over 3,000 clinician predictions, and we published this. What we were able to show is that when a physician says, this patient is going to die or go to the ICU, any idea of how often they're right? Less than a third of the time. So their precision or positive predictive value is less than 33%. When we take a look at the recall or how many cases they actually captured in their predictions, it was also less than 1/3. So ChartWatch, just to give you a sense, its recall or sensitivity is greater than 70%, so more than doubles capture, right? That's what would add value. And when we compare our clinician predictions to things like News 2, our clinicians beat it. So there's no way we would deploy those algorithms because it would just be an exercise in frustration. But if you don't do the homework around clinical validation, you're not going to know. So we need to spend time understanding current state. We look at things like bias. The reality is you'll never be able to do enough. So I believe we looked at around 20 parameters of bias in ChartWatch. I'm using that as an example again. And somebody in the audience, I'm sure, will say, 20? That doesn't sound like a lot. And of course, we'll ask, well, how many should we do? 30? 40? Do I hear 100? There's no standards. We don't know how many bias assessments we need to do. Another issue relates to ethics. We didn't do a race assessment for bias. And I've had people come up to me afterwards and say, how dare you deploy an algorithm without doing any bias assessments on race? It's unethical. And we say, you're absolutely right. Why don't we take the algorithms down? We'll wait 10, 20 years until we get our act together and collect race data well and let 26% more people die every year. Is that ethical? So we have a Center of Medical Ethics that we actually consult with as well. But all of these become real-world decisions that you have to make in the absence of perfect information and data. But those are the realities. External validation and explainability. Most people won't care if it works at another center. They just need it to work at theirs. But of course, you can imagine if you want to scale, external validation becomes important. Explainability. A lot of clinicians are really fussed about this. Why did it alarm? Tell me all the parameters. Give me the Shapley values. I'll tell you, in practice, it gets old very fast. Because the beauty about these algorithms is to understand complex relationships and data that we have a hard time understanding, and it'll take a while to explain it to us. And of course, the analogy here that a friend of mine uses in Boston, he's wonderful, he says, yeah, I was asked surgeons and clinicians, do you use acetaminophen? How many people use acetaminophen on patients or personally? Can anyone tell me the mechanism of action? Nobody in the world knows. We don't know the mechanism of action of acetaminophen. So if you can't explain it, why do you use it? Use it because it works. You can rely on it because it's reproducible. I would say trust, reliability, reproducibility, far more important than explainability. Now, of course, you need it for research purposes and to dig into the algorithms and see how they work from a research standpoint. But when you actually apply these things, it's magical how people just say, God, okay, this aligns with what I'm thinking, it's fine. Because you're too busy to figure out the rest. And of course, soft launches. We spend a lot of time in silent testing. A lot of things can go wrong. So basically, these things run in the background without clinicians knowing what's happening. And we basically see, do the data pipelines fail? Does the data degrade over time? Does the model degrade over time, or data shifts and such? A lot of things can go wrong, so you need to put it in silent testing. And of course, evaluation. Absolutely making sure that you're crystal clear about what you want to evaluate. Communication, what we're able to show in another study is that ChartWatch example I'll go back to, is that the AI is not perfect. It has better recall than the physicians do, but it still makes mistakes. And the clinicians, yeah, they make mistakes too, but they tend to make slightly different mistakes. So the education we typically have is, clinicians, if you think that there's a problem with, if the AI says there's a problem with the patient and you think, no, they're okay, don't believe yourself, believe the AI. But if you as a clinician think there's a problem with the patient and the AI says, no, there isn't, don't believe the AI, believe yourself. And it's the two working together where I think we've seen the benefits and outcomes. I'll just wrap up fairly quickly. Monitoring, evaluation, and maintenance. In the real world, if something breaks at 2 a.m., some of our algorithms update every 15 seconds. So every 15 seconds, you're getting predictions or analyses through AI. If something breaks at 2 a.m., who's going to fix it? It's not going to be IT. They don't have the expertise. So our data scientists, we have a team of 30 data scientists. They wake up at 2 a.m. and fix it if need be. So that investment has to be made in terms of the infrastructure and the people to be able to make these things work. And of course, similar thing around surgery. Lots of different challenges with actually not only developing these things, researching these, but also deploying them. And I would say two of the big ones are temporal and spatial fidelity, because you can imagine if in real time something is guiding your surgery and it's off by a couple of seconds, that could be pretty bad. Or spatial fidelity, if it's off in terms of its grid, that could be a bit of a problem. And what we also hear is over-reliance. Actually, had a colleague of mine at another hospital call me up one time and say, one of the residents just came here and they were used to your place and they're saying, where's our ChartWatch? We don't have one. Well, don't over-rely on it. Not all hospitals are going to have these sorts of solutions, and you'll have a lot of variability. We're all doing millions of things. You should always learn to be a clinician first and foremost, obviously, and I worry that dependence on these tools as they get better and better is going to become more and more, and that's may not be a great thing. So understanding all of these things is going to be really important for us to be able to deploy these things in a reasonable way and bridge that gap between machines and humans in a meaningful way so we can actually glean benefits for our patients. Thank you.
So the next speaker is Dr. Lorene Hatcham, and this is going to be kind of a little bit of a shift in gears, going a little bit toward basic science and regenerative medicine. Lorene's talk is entitled Advanced AI Analytics to Track Endogenous Stem Cells in the Mammalian Central Nervous System, Implications for Regenerative Medicine.
Thank you very much to the organizing committee for the opportunity to present on the panel, and thank you, Dr. Feldman, for joining us today. So today I'll talk about some of the work that I've done throughout the PhD as part of the Surgeon Scientist program here in Toronto, co-supervised by Dr. Fehlings and Dr. Tatter. And really the center of the work focuses on endogenous regeneration of the injured spinal cord. But just pertinent to the topics of Gallie Day today, I'll be highlighting methods to try to integrate large transcriptomic data sets employing machine learning and AI techniques, and really bridging that with wet lab basic science experiments and kind of using both in a way to not only ask questions but to answer them. So a little bit more of the background. So we know spinal cord injury is a devastating condition, and despite advances in the field over years, there is still a lack of validated regenerative approaches, and we know that patients still harbor significant neurological deficits. when we look at the spinal cord, in the center of the spinal cord, this is a cross-section of a transgenic mouse, there's this population of cells called ependymal cells. And they're known to be key players in endogenous regeneration in lower vertebrates. So in lower animals, they're one of the main reasons why they can regenerate the spinal cord. But we know as you kind of go higher up in the phylogeny, and in humans, we know that they're insufficient for endogenous regeneration. They become activated after injury, but we know their numbers are insufficient. So a major question in the field has been what activates these cells acutely, and how can we target that mechanism in a chronic or subacute setting to prolong their stem cell-like state and essentially enhance the body's own endogenous mechanisms for regeneration. So just a bit of background to set this up. We've previously shown that the neurotransmitter glutamate, which is seen at high levels after traumatic injury, is one of the drivers of cells proliferation and activation. So we see that in vitro. Previously, we've defined this mechanism predominantly based on AMPA receptors. So the AMPA subtype of glutamate receptors is what drives these ependymal cells to be activated, proliferate, and migrate. We then went on to prove this in vivo. So we developed this transgenic mouse line in collaboration with Jonas Friesen's lab and Wei Lu's lab at NIH. And essentially on tamoxifen treatment, these mice have knockout of these AMPA receptors. So we wanted to definitively prove this mechanism in vivo. So this work was also done in collaboration with the Valiente lab here in Toronto. So this is single-cell patch clamp recordings. We took these mice, and essentially you can see on the top panel that biocytin is our single-cell recording. We've injected that cell that we're recording in our knockout mice. And you can see in the bottom graph, essentially, in our control mice, we get a large increase in AMPA currents, but in our knockout mice, that's completely abolished. So we've essentially developed this tool that we can now use to prove our hypothesized mechanism in vivo. Then we basically took these mice and induced spinal cord injury, and you can see on the top figure there, we see these labeled, TD tomato labeled ependymal cells are activated 1 week after injury. So you can see they migrate out extensively in the black line, and our knockout mice in blue are completely abolished. And similarly, you can see the average distance of migrated cells is reduced in the knockout. So we've defined this mechanism. We can see after spinal cord injury, these AMPA receptors are driving the activation of these cells. So two questions that come from that is how can we now translate this novel mechanism clinically? And second, what analytic tools can we use to help design the experiments but also understand the treatment effect? So this is kind of the paradigm, the setup of this, the next series of experiments. And essentially, this is time course from spinal cord injury. Very acutely, you get high levels of glutamate, and you get this proliferation in these endogenous ependymal stem cells. And then this kind of dies down over weeks to months after spinal cord injury. The majority of patients we see are in the subacute or chronic period when that kind of stem cell-like state of these cells has gone down to a dormant state. So the question becomes, can we now use an agent that activates these AMPA receptors, that augments their signaling in order to get another bout of regeneration or stimulation? And so there is this class of drugs called ampakines that essentially do just that. They positively modulate these AMPA receptors. So in terms of the experimental design, just on the top left, mice were injured, and after 1 week, we started this chronic ampakine treatment for a period of 6 weeks. So this is basically we extracted these cords. We had 3 groups, non-injured, injured, and injured with this ampakine drug called CX546. Extracted the nuclei, ran single nucleus RNA sequencing. And so on the bottom panel, you can see a UMAP of all the population of cells. So we've essentially recapitulated the 7 major cell types in the spinal cord, including our ependymal cell population of interest. And the right is just showing kind of the markers to define these populations. We first went on to kind of start this large single nucleus study. We use this algorithm called Augur, which is a machine learning framework, essentially quantifies the separability of perturbed and unperturbed cells. So we're using a drug, and obviously drugs act on all cells. We're interested in the ependymal cell population, but we know it acts on every single cell population. So what this algorithm does is essentially it gives you an output in terms of an AUC, higher AUC numbers, meaning cells that are most perturbed or disturbed or responsive to that treatment. So in the top panel, we can see that in injury versus no injury, immune cells, astrocytes, and ependymal cells are the most perturbed cell types, which makes sense physiologically. We know immune cells are highly active and remain kind of so even into the chronic period. Astrocytes and ependymal cells change their phenotype, become reactive, or become other types of astrocytes, so that makes sense. If you look at the bottom panel, interestingly, the most perturbed cell type was that ependymal cell population of interest. And second to that were the astrocyte cells. So we went on further to characterize this. we isolated the ependymal cell population. You can see on the left side, basically this is differential gene analysis, and we can see that significantly upregulated genes comprise genes that are known to be involved in AMPA signaling, which would make sense given the drug's mechanism of effect, and also cell migration. Interestingly, on the right side, so this is gene set enrichment analysis looking at all pathways, so GO pathways. If you look on the left of that, when we compare spinal cord injured versus non-spinal cord injured animals, these ependymal cells in the chronic setting have reverted back to a mature ependymal state. So they're expressing pathways such as like cilium organization, microtubule assembly, which has been known to be reflected in a mature dormant ependymal state. So while they've been activated acutely, they revert back to this more mature non-stem cell-like state. Importantly, on the right panel, we can see when we treat these animals with these chronic augmentation of AMPA receptors, they've now downregulated all those mature pathways. So they're essentially showing a transcriptomic profile of an immature stem cell-like ependymal cells. And we know that that's generally what they do acutely, but this is the first time that any data has been able to extend that reversal of their maturation state in a chronic setting, meaning that we're prolonging the stem cell-like state of these cells. We then went on, so up until this point, we're looking at cell-specific populations and what happens in the ependymal cell population. We next wanted to see, is there any sort of interaction between the cells? So this is another algorithm, basically leveraging AI in single-cell data set, recently published in Nature Communications, which looks at cell-cell communication inference. So basically takes a database of known ligands and receptors, previously trained on inference analysis, and we put our data set through this algorithm. And what we found was that within the ependymal cell population, there was an increased signaling probability of gap junction, so specifically connexin 43. And we went on to kind of corroborate this through histological analysis, and what we could see that indeed there was this upregulation in expression of these gap junctions. The importance of that is that in development, we know that gap junctions couple cells, and particularly stem cells. And there's a lot of literature showing that in acute and developmental setting, ependymal cells communicate through calcium signaling, through gap junctions. If we look back at the mechanism of AMPA modulation, we know that glutamate induces calcium influx into these cells. So essentially, all in all, this data is corroborating the fact that when we're chronically modulating these receptors, we're producing more coupling of these ependymal cells, putting them in this immature stem cell-like state, which is essentially what we want in order to direct their differentiation and allow regeneration. When we kind of then look a little bit more at the phenotype of this result, we see that once we increase these gap junctions and increase the signaling, we also get an increase in migration of these stem cells. So they migrate from the center of the injury to the periphery of the glial scar. We see that there's an increase in that left graph. And then when we knocked out, so we use these knockout mice, when we knocked out the AMPA receptors in these cells, we completely, again, abolished that effect. So further corroborating this mechanistic pathway of migration and immature state of these stem cells. So this was all at, a larger cluster population, so ependymal cells versus astrocytes. We then looked at subtyping these cell populations. So we went on to subtype the ependymal cells. We know there's 3 known subtypes, and this was recapitulated in our data, the ventral, lateral, and dorsal cells. On gene set enrichment, on differential gene expression, we again saw the similar changes in those genes that were changed at a global level in the ependymal population that was recapitulated in these subpopulations. We also, just because of the initial Auger algorithm, we saw astrocytes were the second most perturbed cell type, so glial cells. We also subtyped those into gray matter, so 2 populations of gray matter astrocytes, reactive astrocytes, and white matter astrocytes. We asked the question that, we know that there's important, in development, potential role of glial cells in guiding neuroblasts, allowing regeneration, neurogenesis. So we had asked, is there any sort of potential connections between our ependymal cell population and astrocytes? So at a global level, we found, again, using this cell-cell inference analysis, an increase in the signaling probability between astrocytes and ependymal cells in terms of gap junction. So there was not just coupling between ependymal cells, but also between them and surrounding glial cells. We also found increased growth factors, so FGF signaling between the reactive subtype of astrocytes and ependymal cells. and we found that astrocytes were upregulating adhesion pathways. So that's all kind of from the transcriptomic analysis from the data. Again, we went back to validate this, looking at astrocyte ependymal contacts. So reactive astrocytes are known to express GFAP, and when we did our histological analysis, we saw that there was increase in surface contacts between these two cell types, again corroborating our sequencing data. I'll skip over this for the sake of time, but obviously another important part of any sort of pharmacological treatment is what effect on recovery does this have. So what we found is from looking at various metrics of locomotor function, this drug, this ampakine treatment chronically was increasing various metrics of gait. So BMS, open locomotor score, and various metrics on catwalk gait analysis. We then asked the question, what is the potential mechanism of how could ampakine treatment impact not just the neurons, but is there any sort of crosstalk between ependymal cells and neurons that has not previously been described? So we saw that there was a parallel increase in neuronal sparing, so increased survival with this drug at both an early time point on the left and a more chronic time point on the right. And then we went back to our sequencing data to look a little bit closer at what we could find there. So we again subtyped these neurons into 17 known subpopulations based on known markers in the literature, and then applied the auger prioritization. What we can see on the left, just looking at the top four, on the right, the most right graph, the top four neuronal populations, with this chronic ampakine treatment, we were seeing the most perturbed cell types in the neuron population were dorsal sensory neurons that were involved in sensory gating and pain pathways. So it suggested that essentially it was the sensory gating effect was potentially driving some of the increase in locomotor function, like in terms of proprioceptive changes, and then also potentially effects on neuropathic pain. And then lastly, just looking at what potential, interactions there could be between neurons and ependymal cells. There have been some suggestions in the literature, but nothing confirmed to date. We were seeing increasing cadherins signaling between various populations of those neurons known to be involved in sensory gating and these ependymal cells. So again, this is more so of a question for further research in terms of what potential interactions ependymal cells could have with their surrounding populations. So overall, what can we take away from this work? So basically, overall, it highlights the use of transcriptomic analytics to guide bench-side experiments, and it really is a two-way street. So getting kind of using the big data to ask the questions and narrow down kind of where your experiments will go, but then going back and corroborating your research at the bench. Essentially, this work provides new insight on ways to enhance endogenous regeneration and offers a potential clinically relevant pharmaceutical approach to enhance the ependymal cell response. So I'd like to just take a moment to thank everyone involved in the work. Of course, my supervisors, Dr. Fehlings, Dr. Tatter, everyone in the lab who's been involved, Dr. Valiente's lab for all of the electrophysiology and patch clamping, our collaborators at Karolinska, NIH, and locally, Dr. Peter Dirks, Dr. Graham Collingridge for all of their input and all of our funding sources. Thank you.
Thank you, Lorene. Tremendous body of work. And the next speaker will kind of give us an update on innovation entrepreneurship in surgery, just kind of overall. And, I kind of challenged Jazz to tell us if there are any AI implications of the entrepreneurship that's going on. Jazz, over to you.
Thanks a lot for the introduction. I appreciate it. Good afternoon. Thanks for sticking around. A lot of great talks. I definitely took some notes. All right, so I'm going to give an overview about the Innovation Committee in the Department of Surgery. I'd like to thank both Dr. Rutka and Dr. Swallow for their support over the last 2 years for initiating it and maintaining it and letting it grow, and then for Dr. Fehlings for the platform to tell you all about it today. So the IEC was formed in 2023 with really a priority to push innovation to the forefront in the Department of Surgery. And the vision really is for the department to become a global leader in startups, in innovation, and entrepreneurship, and have a global impact in this area. We'll do this through a mandate that involves building a comprehensive platform for building surgeon founders or launching surgeon founders. The strategy should focus on addressing gaps providing educational resources, technical resources in business and engineering, and financial resources such as access to capital, and ultimately foster a supportive and creative culture within the department. We ultimately report to the research committee, and so hence we thought today was a good opportunity to update everybody. A quick note on culture. Culture really, I think, is the only sustainable long-term competitive advantage. You take any organization at its core, whether it's a hockey team, a department, a surgical department, or a business unit, how people work together and their patterns of behavior really, I think, drive the likelihood of success. So I think building the right culture around innovation is important. Building a culture that provides the conditions for growth, the essential nutrients for like an idea fragment that's very vulnerable, and taking it to completion is super important, and really sets the foundation for future success as a unit. I think we need to celebrate achievement, celebrate translation, going from bench to bedside, embrace failure as growth, whereas maybe failure is a stepping stone for some people. Create a startup ecosystem where ideas can go to market. There's so many great ideas presented today, and I have no doubt that some will lead to commercialization. And really, innovation should be an academic currency, the 3 Ps. Do people have patents? Do people have prototypes? And are there pursuits, entrepreneurial pursuits, that either lead to success, funding, failure, but I think the initial intent of trying and doing something unique is what should be noted. And we have a website launching soon. It's been in the works for a while, but we got some money from Dr. Swallow, so thank you. But ultimately, we want to launch the next generation of surgeon founders. And this website will be out probably this month, latest June. And it's designed to do many things, but one of the things is if a user gets on the website and they want to create an AI startup, or they want to bring an AI algorithm to the market, they have an idea. It'll set them up with down the appropriate pathway in terms of content, education, mentors, and networks. If they have a patent and they don't know how to go to the next level, it'll connect them to lawyers, IP experts, perhaps some funding. And if someone has a startup and they just want it to grow, it'll be a different set of levers they'll be exposed to, and sort of a bespoke presentation of content, depending on where you are in your journey. There's already so much happening in the university. I think just this afternoon, we heard so many great stories about how machine learning and neural nets and AI in general is being used to transform prediction. AI is really a tool for prediction. Are you going to be more right, or are you going to be less wrong? And here's a few things that's already happening. You have all these companies. Oops, sorry. Is there a laser pointer, or maybe not? For example. Okay, great. You have, for example, Karen Cross, who is a founder of Mimosa Diagnostics, has a handheld point-of-care device that detects skin temperature, skin oxygenation, perfusion, and provides real-time heat maps that can be used for many settings, including post-op care and preventing complications. Christian Vayet has created Datos, an electronic data capture system for clinical outcomes, translational research, and he has sites across North America collecting data. And this is really, data is the key resource for all of this work around AI. So he's building an ecosystem around data and how to capture it and present it in the right way, including some of these dashboards. For example, Dr. Paul Walker, who's an innovator in, with spectral medical, looking at endotoxin shock and how to detect endotoxin in an at-risk population. So I think there are so many examples of startups and innovation already happening in the Department of Surgery. And these are actually a list of active startups right now, mostly not in AI, but some in AI and prediction. But I think it's a very exciting time, and I think really things are changing really, really fast. Promise I'm almost done. What are we doing now? We're trying to go back to our vision and our mandate. Bi-monthly webinars related to innovation and entrepreneurship in surgery. A new annual award for Innovator of the Year in the Department of Surgery, the first one to be presented tonight. Early career surgeon, could be a resident, could be a fellow, could be a trainee, but first 5 years of practice. An award for the best innovator. Development of a surgeon entrepreneurship career path. What does that look like? How do you get promoted? What kind of salary support is there? How much protected time is there? I think there's a lot to carve out, and that's something the committee will work on. Educational content for residents in resident education day across the various subspecialties. It should be a uniform presentation of content. Partnership with engineering, the hatchery and Rotman and so forth, and working with the advancements office to raise money. Why do we need money? We need money for pitch competitions like we had in 2023 so you can have non-dilutive financing. Maybe some sabbatical support for mid-career faculty who want to go back and focus on innovation. Maybe some salary support for surgeon entrepreneurs who are hired right out of fellowship. Perhaps creating our own educational platform like Toronto Biodesign, if we have the opportunity to link up with Stanford and kind of extract and use some of their techniques around innovation. So ultimately, here's the committee. Thanks to everybody. Thanks to Dr. Ori Rothstein for making the committee happen as well. Ultimately, I think we want to build an ecosystem where innovation is not just an option, it's not just possible, but ultimately it's inevitable. So thank you very much.
Thank you, Jazz, for your leadership on this fantastic committee. And Professor Feldman, could I ask you to come on up as well? And we have a few minutes for our panel discussion, and I would invite questions from the floor. And I actually wanted to call on someone. This is totally impromptu, Paul Walker, but your name was mentioned, and maybe you can think of an intelligent comment to make at some point. You have a little bit of experience in terms of the bench to bedside model. So I kind of had an open question here, and so here we are, and this is kind of a rapidly evolving field, and we've heard about the use of AI, machine learning, deep learning, and kind of different approaches. So in terms of right now, what could maybe the panel give us maybe 2 or 3 examples of where we're actually able to use AI like right now in our clinical decision making. And I think we heard a few in transplant and so on, but maybe just to kind of to summarize this, because I think one of the themes here, this is a lot of information to take in. And sometimes it's helpful to just kind of summarize a few points. I don't know if anybody wants to take a stab at this.
Sure, maybe I can start. I think there's probably some low-hanging fruit that we could tackle now. We've actually seen some kind of nice concepts like the Fehlings chatbot that would really help with pre-op and post-discharge engagement with patients to really prep them for surgeries and also answer any questions they may have afterwards. I think that would be an easy win. The other is pre-op in terms of diagnostic assessment. For example, the algorithm that I'd shown around traumatic brain injury, that's actually live up and running. And that will actually help neurosurgeons actually with all the cases they have to triage. That shouldn't exist that a neurosurgeon has to wake up at 3 a.m. only to realize that the consult they have just was a waste of their time. That could alleviate some burden. There's also other spots in surgery where post-op monitoring, so for example, complication prediction. There's algorithms there as well. We actually have, again, an algorithm running in our general surgery unit to predict if somebody's going to deteriorate. So those are live up and running now. They've shown to be effective and work.
Cool. Any other comments on that question?
Yeah, just to add on, I think, say in the U.S. across many institutions, there are, say, certain early warning systems for different applications that are operational. Now, AI tools are particularly able to leverage imaging data. So if you look at the over 950 FDA approved AI tools, they're mostly in radiology, pathology, and endoscopy. And I think those are already being deployed and in use across many institutions worldwide. The other thing is, say, AI scribes, so certainly to alleviate the work burden, writing discharge summaries in an automated way. You know, there are various AI applications that leverage language, text already that are in deployment. So I think, you know, the future will bring the ability to bring together all those different types of data, you know, multimodal, to then generate even better predictions, you know, in terms of early warning systems, et cetera.
Yeah, cool.
I'm
Leanne?
just going to say
Yep.
in a practical way, I mean, ambient AI applications are, you know, available. You can, we use one that in my environment where you could have a patient interview in either French or English, and it'll make the note in either French or English. So depending on, I mean, that's extremely useful. So that's just, and I think ChatGPT for things that just are annoying things that it saves you time to do, like writing letters, writing emails, writing reports. So not fancy, but things that could save some time. As we get to use them, we get better at using them.
Yeah, and I've, you know, kind of seen some interesting, you know, kind of early developments in the use of AI to just kind of facilitate putting together clinical records and summaries and that sort of stuff. Okay, great. Some questions from the floor. Fantastic.
Yeah, it's great. Lots of interesting work, lots of different areas. I'm curious about, I guess everything seems very neat and tidy when we put it all in a talk. So I'm interested in, what do you think the biggest challenges are to using AI either in your practice or in your research? I'm certain I have my own opinions, but I'd really like to hear what everyone's experience is.
Yeah, open-ended.
Sure, I can take this one. For us, or at least our area, which is, you know, handling video data, especially 4K videos, are very heavy duty. How do you move that data? Creating the logistics and the infrastructure, trying to figure all that is I think the biggest challenge that we face. Collecting the data, setting it into a machine learning pipeline, deploying it, like all of that is moving data everywhere. So I think that's a huge challenge. And you know, right now we have a lot of cool AI algorithms, but you know, how do you send that into another part of the world, a remote region of the world? You don't have any infrastructure to use that AI. That I would say is the biggest limitation in my area.
Dr. Rubin?
Thank you. So that was sort of my question. So for those who don't know me, I'm Barry Rubin. I'm actually co-lead for AI deployment at UHN. And I want to know from the panelists, what's the biggest challenge that you faced with deployment, but more so, how did you overcome that challenge to actually have the AI running in the clinical environment?
I did allude to this earlier. So we had that, paper published a few years ago, with the transformer model, but unfortunately we were unable to successfully deploy that model because it was leveraging over 167 variables, longitudinal changes, and generating hallucinatory predictions, we realized, when we actually tried to deploy it. So our data engineer, created the back end and was able to integrate the dashboard into Epic. But then when it came to actual deployment, we realized that it was generating unusual predictions. So we realized that we had to pare down the model and then really focus on one outcome of interest at a time. So we then decided to pare it down to just cardiovascular risk prediction, which is an important cause of mortality after liver transplant in over 25% of recipients. So we just decided to pare down the number of variables. So we brought it down to like 20 variables and just made it simpler for our electronic medical record system to handle. And now it's generating predictions that make sense, and now we're implementing it into the clinical setting. So I think the lesson from there was that certain heavier models, like computationally heavier models, may not be easy to deploy. Now, when it comes to Dynameld, which is the algorithm that leverages a smaller number of variables, so 13 variables, but also time-varying changes, that appears to be deployable, and it's giving accurate predictions. So I think there we are also leveraging something that's computationally less heavy and also a lesser number of variables. So I think one important lesson I learned from this was that, heavier models, a larger number of variables may end up being too difficult to deploy, and so it's better to be a bit simpler when it comes to deployment. And I think Mohammed would agree with this. I think that's the lesson I learned, because we really struggled. Like for over a year, we struggled to deploy this model, and yeah.
My takeaway from that is that hospitals have to invest more in compute power and memory to enable use of the more functional large language models like you've described.
Yeah, yes.
Dr. Rucka?
Yeah, thank you very much. I enjoyed the panel discussion. In November last year, I was in San Francisco, and I had one of these never-in-my-lifetime moments. I was on the streets near Union Square, and all these cars were going by. They were white cars. They had these little buckets on the top. Passengers were going in. They were driving off, and they didn't have drivers in them. So driverless taxis, I didn't think I would see, and it's kind of old hat now. And just all day today, we heard these wonderful presentations of things I don't think we would have imagined in our lifetime. My question is, one of the issues that was mentioned at the beginning of the day and also came up here was the fact that AI is limited by not being exactly current all the time. And one of the problems is that a lot of information still is behind either firewalls or password protected in journals and textbooks and so on. When everything is open access, open source, everybody sees all the information in the world, how will that improve the models about which many of you were talking in your presentations today? Will that improve your models dramatically or just slightly? What do you think will happen when all information is freely available to these large language models?
Who wants to take that one on? Wow. Wow, cool.
I can comment on that. We've actually done a little bit of work on that. And the kind of classic econometric curve that's been known for like decades and decades, I think rings true. So basically the way the curve works is that your model performance increases as you input your data, as the number of features increases, and then it starts to plateau. So it kind of reaches a threshold where you put in more data, it's not going to make much of a difference. And then you start putting in more data, and it actually starts decreasing in performance. And it's going to really be driven by the question you're trying to answer in the context. But what we typically find works really well, at least in our shop, and I imagine you may have found the same thing, is that you start with the clinicians, because intuitively you're making decisions with a certain data set in your head. You figure out what those variables are and the permutations of those variables. Then you do a data-driven exercise where you say to the computer, all right, you go look for stuff. You bring that list back to the clinical team, and the clinical team then says, man, I gave you 20 variables, this is pulling up 200. These are totally dumb because they don't make any sense, but these I never even thought about. And we find that's the best way to do it, because then you actually have variables that are important to clinicians. You don't overfit the model with too much junk in there. So it's a bit of a methodical exercise in terms of getting the right data you need for the clinical problem you're trying to solve and not getting too much.
Cool. Dr. Walker, I see that you've risen to the challenge.
Well, you asked for an intelligent question, so I'm struggling. I just want to make a couple of comments. I mean, I'm old enough to have seen the Department of Surgery support surgical scientists, epidemiologists, administrators. So I'm particularly pleased to see Department of Surgery supporting surgical entrepreneurship. I was very entrepreneurial, and in 2001, because I wanted to go forward with that, I had to leave the department. There was no choice. You were conflicted, you weren't recognized, and it was considered going to the dark side. So to embrace this within the Department of Surgery, I think is futuristic, and I think it's critically important. It is a tremendous struggle. And Jazz, I like to see what you're doing, and I like to see the progress you're making. It's painful, and you talk about failure, and of course it is part of it all. I don't think we want to condone failure as a future. It isn't necessarily a failure. It may be a failure in this road, but a change to that one. So that's point number one. The second is that we talk about bench to bedside, and just giving you an example, I've been at this for more than 25 years now, and I'm taking something from bench to bedside. In the middle of that is, particularly for recognition as well as regulatory approval, is the FDA. And I probably had to learn more about the FDA than I want to, but it's the big roadblock. So my suggestion to you, because I didn't see it up there on your list, is that you have in your educational program an understanding of what the FDA is, because you don't get anywhere with a product. You can't sell it unless it's approved. Having Health Canada approve it is not effective enough. Certainly, you can't sell it in the States, and it doesn't have any recognition worldwide. So your program for education and all the different things you're talking about, part of the planning process must include a regulatory pathway that is robust, because that is where most companies fail. And that's my one comment on that, but I appreciate the opportunity that to be here and to see the progress that's being made in the entrepreneurship program. So thank you.
Great, thank you, Paul. That was coming from a lot of experience, food for thought for sure. Comment, Jazz. Sorry.
I was just going to thank you for your comments, and I agree. Like, regulatory frameworks are important, and the FDA is paramount, so we're on it.
Yeah. Good. All right. Perhaps the final question to Dr. Michael Cusimano.
Thanks, Michael. Clearly we're on the cusp of a revolution here, and I want to thank all the panel members and for Michael and Carol and everyone for putting it together. The question I have is, who owns the data? Do the patients own the data? If we do, everyone knows the HeLa story with cancer cells. And to what degree do we address that part of the ownership in our relationship with patients? Because that could really make the whole system tumble down. I heard people talk about ethics and these other soft things, but I think they're equally important to address as to the hard science part. So I'd like to hear some comments about that from panel or people with experience in the audience.
It's actually a great question, and a couple of the talks today kind of alluded to just issues maybe at a more narrow level, but just simply copyright issues. Who owns the intellectual property, and the assumption that things are published, but does that automatically mean that you get to use this, and then who actually owns the data, genetic data, phenotypic data, and so on. It starts becoming quite an interesting issue. Wow, who wants to take? Who would like to take? Who would like to take that one on? That's a biggie. But maybe a few brief comments before we wrap up.
I think it's a very, very important issue, and certainly comes up a lot with, let's say, the stuff that we were interested in, which was this use of video data. So right now, it's one of the questions, like is it part of the medical record? If it's part of the medical record, then for sure patients have access to it. So the way that we, and then that becomes a philosophical question, as I mentioned, because if you're using it like to review when a patient has complications, if it's part of M&Ms, then perhaps it's part of that discussion at M&Ms, and maybe it's protected. But it hasn't really been challenged, to my knowledge, in jurisdictions, to my knowledge, in terms of using video. Maybe Amin knows, but that I don't think it's come up yet. But it's certainly a question that surgeons are very, very, very concerned about. One of the ways that we have tried to assuage people's concerns is we are getting patient consent for video recording. And it does go through that, in that consent, that patients they won't have access to the video. And then when I deal with an individual patient, I mean, the context is important, obviously, and if we want to review parts of it, it's in the context of a discussion that I'm not just giving the video, because I think that would, I don't think that would, that has the potential to be taken out of context if you're not used to watching surgery. But I think it's a very deep question.
It's a great question. I think it's actually quite appropriate that our visiting professor and Gordon Murray, a lecturer, has closed the comments. I think I'm going to take chair's prerogative and suggest that further discussion be taken offline under more casual circumstances. We've had a fantastic day. So I'd like to thank the panelists for some fantastic, very thought-provoking discussion. Thank you so much. So I think we're going to wrap up the afternoon. We've had a wonderful a day of fantastic presentation by Professor Leanne Feldman, just an amazing Gordon Murray lecture. Wonderful presentations by our trainees, those in the surgeon scientist training program, and many trainees who are outside of the training program, but very much integral to our Department of Surgery. Fantastic panel discussion. So I'd like to thank a few people. I mentioned a number of these, this morning. Big thanks to the department, to Carol for all the support. A big thanks to Amin Madani in particular for kind of helping to kind of organize a lot of the themes and suggestions around a number of the speakers. Big thanks to our two resident members of our research committee. I acknowledged them this morning, but I just want to again repeat Yosef, Ellenbogen, and Asha. Behdinan had a really lot of help and support. Thanks to all of the oral presentation, abstract reviewers, e-poster judges, and discussants. You were acknowledged in the slides this morning, too many to mention. And then finally, big thanks to our amazing administrative staff, to Sylvia Perry, and in particular, huge thanks to Renata Musa. On that note, I'm going to hand things over to Professor Swallow to close things out.
Thank you, Michael. I think that's a thanks to Michael. And I want to thank, on top of that, all of you for being here. This department, this Gallie Day makes me very proud of all of us. I think Leanne may have some remarks for us later this evening, but it is just an honor and a privilege to lead this department. We're up there. I think we're number one, don't you, Jim? Yeah, I think so. And thank you so much for staying and participating all day long and participating in this panel discussion. You're amazing. This evening, I just want to make a note. Do not go to the Royal Ontario Museum. Do not go to the Gairdner Ceramic Museum. You are going to the Art Gallery of Ontario. It is on Dundas Street. So make sure you see all of us there at 7 p.m. for cocktails, the dinner's at 8. We really look forward to a great turnout and a celebration of our award winners of all calibers. So thank you, and have a great evening. Bye.